chest wide open, heart in my hands. What's up, everybody? It's your boy Wakar, your local trauma trained, board certified ER physician, and I'm coming to you hot with a wild story. Now, this one's graphic, so be sure to lock in and please take a seat. And if you like stories like this, be sure to like and subscribe and comment down below what your thoughts are. Now, this one starts off with a guy in his mid 40s, African American individual who presented to our emergency room with a stab wound to the left side of his chest. Now, that's crazy, and you already know this is going to turn up quickly. When this individual first came to our emergency room, he was super stoic, actually rather cool, calm, and collected. Wasn't offering much, wouldn't give us any information in the little time we had to gather anything. He even at one point said, "Fuck off of me." But obviously, as his medical team, we weren't going to let words like that deter us from giving him the best possible treatment and the best shot at surviving. So, in minutes, nurses are rapidly gathering supplies, putting on the EKG leads, getting him on the cardiac monitor, acquiring IV access in the event we have to give this patient blood or fluids or antibiotics. And again, patient rarely offering up any information, barely even giving us eye contact. At even one point, like withdrawing his arms when we are trying to utilize them to tap into his veins, again, to give him what he may need in the event he deteriorates, like blood and IV fluids. And again, cool, calm, collected, arms crossed, barely offering any information. Quickly, as an ER doc, our responsibility is airway, breathing, circulation, right? Is the patient talking? Does the patient have bilateral breath sounds? Does the patient have pulses? What's his mentation like? Get him exposed to make sure there's no injury that we may miss, secondary to focusing on the most obvious one, which is this penetrating chest wound. And what was crazy and something I'll never forget is, again, the room was chaotic, right? But as we got him on the monitor, his heart rate, it was like a movie. 100, 80, 75, 40, like plummeting. And as it was plummeting, his eyes literally started to like roll to the back of his head. His arms starting to slouch downward. My ER resident had a probe, an ultrasound probe, something you'd use in the setting a woman who's pregnant and you want to take a look at the baby. But this time you aren't looking at a baby. We had it to his chest where that penetrating wound was. And what we saw was his heart, which is normally enclosed in a sac called the pericardium, was floating, swinging like a pendulum. And as his heart rate was rapidly dipping, essentially about to hit zero, my fellow surgeon took a scalpel, an 11 blade, insanely sharp, and obviously at the head of the bed, one of my ER residents is bagging the patient, oxygenating them in the likely need for an intubation, but that's a whole different topic. What we're talking about here is his heart floating in a sack. The surgeon took an 11 blade right in this area here, in between the fourth and fifth rib, just in front of the anterior axillary line, which comes down here. Stabbed him right there, quickly took out the blade, popped his fingers in, and no air came out, which is the first step to make sure that if there's like a significant lung collapse, but nothing came out. He then quickly took his scapula and made an incision going from the left fifth rib anterior axillary line all the way across, and then quickly took a scissor and in that same hole put the scissor in the hole and started cutting this individual from the left anterior axillary line all the way across to his chest. Wild. And it gets even crazier. I then jumped in, took what we have called rib spreaders. Now, essentially, think of it like your car tire pops, right? And you got to get that car off the ground so you can adequately have enough space to change that tire. So you put your car on like a jack and you just crank until that car is high enough off the floor so you can get the job done. Essentially, we put this rib spreader between his fourth and fifth ribs, and I am just cranking it. Crank. Fourth and fifth ribs pop right on open. And then we see essentially his heart. And what we do is I take forceps, I grab a piece of the pericardium, I then take a blade and I make that incision across the pericardium and extend it enough to ensure I can grab the heart. And when I do that, blood comes flying out. I'm talking a ton of it, along with some clots too. We rapidly then grab the heart because at this point we're anticipating that the right ventricle, which is the most anterior part of the heart when it sits in our thoracic cavity, has been punctured, right? Blood shouldn't be in that space. So we quickly grab the heart, try to remove it from the pericardium to the best of our abilities, and then we take a quick look at the heart, and there it is. There's a hole, and with every beat, more and more blood just squirting on out. I quickly just take my finger and I just put it right in the hole. Right in the hole. And the surgeon looks at me and says, "Keep it there because we're going to the operating room." And I literally, with that patient, chest wide open, heart in my hands, with the fingertip in this hole, and now creating a blockade to prevent the blood spewing out from his right ventricle into the environment. Now, unfortunately, the injuries were too severe and the patient ultimately didn't make it. But I will never forget that experience. How swift that surgeon was to go ahead and do this procedure because it's what the patient ultimately needed to have the best chance at survival, right? The procedure is called a thoracotomy. And ER docs, along with trauma trained surgeons, are capable of doing this procedure. And the indications are for a traumatic arrest. Now, traumatic arrest could be secondary to blunt trauma, for example, a motor vehicle collision, right? Or it could be to a penetrating trauma, like a stab wound or a gunshot wound. And essentially, we only do it if the patient has failed resuscitative measures like blood and or like hemorrhage control, or if we think there's a injury such as a penetrating wound to the heart or extreme lung collapse causing what's called a tension pneumothorax, and the patient essentially codes or is like peri-code. And in this situation, the patient was seconds away from coding. So the surgeon, acted upon his instincts, knowing that given the ultrasound findings, given this heart was encased in a pericardium that was filling with blood to the point where you see this heart swinging, I absolutely would not have changed anything we did. But that's what a thoracotomy is. You are essentially trying to get to the source of what's causing the patient to code, or you're essentially attempting to limit blood flow to a particular part of the body, such as the extremities, in an attempt to minimize blood loss and also like maximize blood flow to critical organs such as your liver, kidneys, brain, and heart. Um, so the procedure consists of making an incision in that left fifth intercostal space, which is between the fourth and fifth rib, a puncture wound, and then sticking your finger in and trying to feel the lungs and seeing if the lungs are inflated. If you do this, and you're supposed to do it on both sides, but in this situation, we only did it on the left because that's where his wound was. If you get the patient to return back to life, as in his heart starts to beat again spontaneously, you can stop there after you put in maybe like a chest tube. But in this situation, again, we were worried about the heart being punctured secondary to the blood being accumulated in the pericardium, which is the sac around the heart. So we knew we had to go further, which is why we took, the scalpel and the scissors, and we cut across from the left fifth rib along the anterior axillary line, which is just in front of the armpit, all the way to the center of his chest. And in some situations, some providers would actually do that on both sides, so they can cut a hole on the right side and on the left side, make double incisions, go across all the way to the midline of the chest, and then essentially crack open the chest so you can get like a bird's eye view of the heart and the lungs. And they call this a clamshell view. As you can imagine, we're clamshelling open the patient. It's pretty gnarly, very graphic. Um, Something out of Mortal Kombat, to be honest. And yeah, essentially after you get the heart out of the sac, you can evaluate the heart to see if there's any trauma, and if there isn't, perhaps maybe there's an injury to the abdomen. What you can do is then you can compress the aorta, which is the essential largest artery in the body that is responsible for providing branches of blood flow to the rest of our body. And you can tamponade that with your fingers and cut off the blood supply to anything past that point. Again, reserving blood flow to the most vital organs. Super graphic, doesn't often happen in our emergency room. As you can tell, the procedure doesn't have the highest likelihood of survival, but there have been patients that have survived this, and I personally have taken care of them as well. I once had an 18-year-old that was speeding down a street without a helmet, unfortunately, and collided with a U-Haul truck. He came in a traumatic arrest, and it was a blunt traumatic arrest. And typically, we don't do these procedures on blunt traumatic arrests because their chances of survival are insanely low. And as you imagine, this is a super dangerous procedure for both the provider and obviously the patient, but with less to lose for the patient because you're doing this if they're unfortunately dead in a cardiac arrest. Um, we did it on him because he lost vitals in front of us as he was like stretchered into our trauma bay. He literally lost vitals, and in the setting of blunt trauma, the only time you're really supposed to do it, and guidelines vary east west, but he lost his vitals, aka his heart had stopped in front of us. We went ahead and did it on him, essentially the same procedure, right? An incision in the left chest wall and cut across to the middle of his sternum, separate his ribs. In his situation, we didn't uh, focus too much on the heart. We did take a quick look, but there was less suspicion that something like a hole would have been there. But so we focused mostly on cutting off the circulation to below his diaphragm, essentially. And he survived. He survived. Unfortunately, he did lose his left arm and both of his legs due to the lack of blood flow from the procedure, but ultimately was discharged from the hospital. Again, this procedure is incredibly dangerous, has very poor outcomes, but if there's a penetrating trauma and you essentially lose pulses, whether it's in the field and it's witnessed by emergency medical services or it's in the hospital in the emergency room witnessed by providers like myself and the trauma team, this is something that we would do. It's a very heroic measure, but it's the last ditch effort to help the patient survive. Now, that's a thoracotomy. That's just one of the few badass things I've personally seen and taken part in. Literally, again, holding a heart in my hands, fingertip in hole to plug the bleeding, and we're doing what we can to get this patient to the operating room so he can get definitive care. Now, ladies and gentlemen, if you like that story, be sure to subscribe to the channel, like the video, and comment. And if you want to hear more stories like this, let me know, because I have a ton of them. I have sad stories, trauma stories. I even have things such as items in places where they shouldn't be stories. Wink, wink. So if you liked it, I hope you learned something. Again, subscribe to the channel. Hope to see you guys in the next one. My name's Wakar, ER Doc. Love ya. Peace.